patients on the unit. You will learn more when things happen. This will just kind of help you. Some of this you're already going to know from taking care of these patients on the units. So, okay, so the pathology, what's our nursing interventions after they go home, signs and symptoms and the treatment goals, and the differences of angina and MI. Okay. So coronary artery disease is the impaired blood flow to the myocardium. So this is very common, like more than 3 million cases each year. Requires lab tests or imaging to know that they have this. This can last for several years, or they may have it lifelong. It's common for ages 50 or older and more common in males. Okay. So this is what happens, a lipid deposit of plaque. You know, it's narrowing that artery, so that blood is not getting through to where it needs to go. Progressive disease characterized by plaque formation. So what's our risk factors? Of course, we know that's smoking, right? These are modifiable. Non-modifiable is that your age, your gender, your family, your history, right? Family history. You can't change that. My heart doctor, cardiologist the other day said your high cholesterol is 80% genetic. 20% you can change by losing weight, exercise, this or that, but 80% you have no control over. So, you know, if it's in your family, you're just going to have to do the best you can with that other 20%. So these are the ones we could change: is the smoking, the weight, right, the diet, the blood pressure, you know, that can come down with losing your weight and diet. What does A mean? Anybody want to guess? What does A mean? Was it Dana? I told we talk about her today. This is Dana. What do you think A means?
Alcohol?
No, that's a good guess. A lot of you guys are this. You may not accept it, but you are.
Blood type? Anxious.
No. What was the other one? Not blood type.
Anxious?
Anxious, that comes with it. That's not it. I know you're anxious. We all, especially day for a test. I understand. Any other guesses? How many of you are type A personalities? And type A is very big with their stress that leads to heart attacks when they're young. Right? So do those stress relaxing things. I know it's rough for some of you. Does that make sense now, Dana, when I said we talk about you today? Okay, so that's risk factors that we can change or try to help work with, right? Try to lower our excitement there. Medications, of course, is the statins. These are the first line drugs for treating the hyperlipidemia. A lot of people are allergic to statins, cannot take them, you know, so they have to try them on something else. You know, I'm not going to quiz you on what are these certain medicines or anything. You know when you take care of patients with heart problems that they're going to be on all these. The fibrates will lower the triglyceride levels, aspirin possibly. So aspirin prohibits platelets from sticking together and prevents clot formation. So they recommend 75 to 81 milligrams a day. But you got to watch, right? Long-term use will cause bleeding. So you do want to make sure that patients understand that. You know, as a nurse, you're always educating, right? Every time you walk in that room, you're doing some kind of education. How are we going to diagnose these people? Of course, with the EKG. They may have the ST segment, which we're going to get into in just a minute. The exercise stress test, does their heart change while they're exercising? Did the rhythms get worse, dysrhythmias, or the heart rate go up? Echo's going to show us where the heart muscle has been damaged. The myocardia person imaging test, that is just more the blood flow to the heart muscle. The CTA scan, it should have an A with it. It visualizes coronary arteries. So these are just different tests that may be done. I'm going to try, I was just thinking as I was getting started, to make you up like a chart to show the differences in these. See if that'll help you when you study for this next test coming after. Okay, angina pectoris. So this is chest pain that results from the reduced coronary blood flow. So a lot of people come into ER, they think they're having a heart attack, and it's actually only angina. Now it's scary still because it's chest pain, and you know, they may be that age, it may be overweight, so that's why they think it's a heart attack. So we're going to talk about the 3 different types. So stable angina is the most common, usually when they've started doing more physical exertion. Say they haven't walked for a while and now they're going to go out and walk a mile. Ooh, that's too much to their body, too much a shock all at once. They didn't like build up to it. If they've been exposed to cold or stress may cause this, which I know you guys know you have stress, but treatment, usually it's going to be relieved by rest, and they may have to give nitrate, so nitroglycerin. But usually sometimes they just rest, that's all they need, and they're fine. So we call it angina because it's not complete blockage. It's not an actual MI. So Prinzmetal's angina is not related to activity. This usually happens at night. So, you know, they wake up and all of a sudden they're having chest pain. You know, they haven't done anything, nothing's brought it on. It's still considered a stable angina, so they're still going to treat it the same way. You know, rest again and nitrate. Maybe get rid of whatever may be causing stress. They're not even realizing that stress is pushing on their, you know, body system there, their mind. Then we get the unstable angina. So this is a form of acute coronary syndrome. So the heart isn't getting enough blood flow and oxygen. So this is the one we're going to have to make sure we get them treated before they get into the actual MI. So there's a couple of different ways to know the stable and unstable angina, and how the plaque is showing there. Unstable, it's still no infarct, so no MI going on. We may have some ST depression with it, but not ST elevation, which we'll talk about in a minute. So again, how do we diagnose this? It is based on the family again, past medical history of their self. Do they have any of these risk factors? Is a 12 lead showing it? Has the echo showed some problems? And again, the CTA scan. Okay, so medications, here's our nitrates. Again, we're going to give them the nitroglycerin. May give them the beta blockers. It's a first-line drugs. We may give them some calcium channel blockers to help with that oxygen demand, myocardial oxygen demand. And then again, aspirin. We're going to reduce the risk of platelet aggression, reduce those blood clots from forming. So you'll see the medications through all these are pretty much going to be the same for these angina and acute coronary syndromes. I don't like the way the book lays it out. I tried to follow it, you know, that way. I don't like how they got it laid out, and that's why I thought, well, maybe I'll try to make you guys some kind of chart to maybe understand it a little better. So acute coronary syndrome is unstable cardiac ischemia. So the blood flow is reduced but not fully occluded. Okay, so that's the big difference. The chest pain can last longer than 10 to 20 minutes, and it can occur at rest. Going to diagnose it the same way. We're going to go over the markers a little bit more in depth here. We're going to treat it, you know, by drugs, some procedures, maybe even the CABG surgery if it gets into that. The drugs, again, nitrates, beta blockers, aspirin, and heparin. The symptoms, chest pain, dyspnea, diaphoresis, tachycardia. So our lipids, so this is your cholesterol. I think I meant to look because I think these numbers might have changed a little. So people may not have any signs of symptoms of the arteriosclerosis until the blood vessels become narrowed. So the monitoring of the blood lipid levels gives our early indication something's starting to happen. So that's why, when you go to the doctor, they want you, as you get older, those of us, you have your cholesterol checked a lot to see if anything is changing with it. Cardioprotective lowers the risk of heart disease, so we want that. We'll talk a little bit more about this next week with the surgeries, but this is your PTCA. So this is where the stent is put in and open up to let that blood flow go through. So they go up through the femoral artery and open up those blocked arteries so that blood flow can go through to the heart muscle. Those of you still working on your extra credit, don't forget extra credit. Find you a movie about this or a good tape, a good thing showing some of these surgeries or an MI or something, and use that as your extra credit, okay? Those of you who went to AA, I meant to tell you, very good response when you went to your AA meetings. I really enjoyed reading those, and it is very interesting. So don't forget your AA meetings. So I'm thinking about that. Okay, so now we're going to get into acute MI. So let me show you a little video clip here. It's not very long. Show it there. I used to have a great movie, and I cannot find it anymore.
I can't hear it very well.
I was going to say, I can't either. Let me hang on a minute. I didn't know if it's just me or turn this up a little bit here. Getting better? So there's a lot of those little videos you can look up and watch about heart attack. That okay. So acute MI. So this is disruption or deficiency of coronary artery blood supply, so resulting in necrosis of that tissue. So arrhythmias, you're going to see, of course, ACLS. We probably won't do any of the videos today, but we'll do them next week. We'll have more time. I know today you're going to be brain dead with all this. But we have to get through the rest of our ACLS videos before you do your practice on that Thursday. So this is what you'll see, of course. So what's our complications? Dysrhythmias. So this is due to the ischemia of the pacemaker cells. Pump failure is impaired contractility, and filling may produce the heart failure. Cardiogenic shock. When we get into shock, we mainly focus on the cardiogenic and a couple other kinds. This results when functioning myocardial muscle mass decreases by more than 40%. Infarct extension, this is 10% of the patients experience reinfarction in the area of the original heart attack. So within the first 10 to 14 days after the heart attack, they have another one right in the same place. So that's rare, but it does happen. Structural defects, ventricular aneurysm, something's ruptured in that myocardial system. And then we talked about the pericarditis. So those are different complications you can have because of the MI. So our treatment goals is relieve that chest pain, reduce the extent of myocardial damage, maintain cardiovascular stability, decrease that cardiac workload. We talk about that a lot, and prevent complications. So these are the markers we're going to talk about. First one is our cardiac enzymes. Now, each place you work, you're going to see each system, they may have a little bit different on their numbers, okay? So the numbers I tell you is the ones you're going to need to know. For me, now you may go to wherever you work or your clinical, and it may be a little bit different. So this is when your markers are going to peak. So like here they infarcted, and here your troponin is in the red. It's going to peak mainly that first day, but it's going to start going in every 3 hours. Those of you that work in ER, I meant to check yesterday, but we used to do 3 sets of these that we called the AMI profile then every 3 hours to see if there was any peak. I heard it was just 2 now. Is that right? Anybody works in ER?
They still, if they get them up to the floor, they still do 3.
Okay. Because, they don't want to do 1 and nothing showing, and it's happened. They send them home. They end up having a heart attack and dying at home, because it hadn't peaked yet. Everything else looked good. Hey, they're not having a heart attack. Let's send them home. So they try to do, at least 2 and usually 3 to make sure something's not changing with these markers, so they know there's something going on. My brother-in-law years ago, he'd had a heart attack, didn't have to have surgery. Well, he started having chest pain again a few years after that. He came in, his labs was fine, EKG looked fine. They admitted him. This was a Shelby. The doctor was going to do stress tests the next morning, and he just was like, I don't know. I think I'm going to take him for a cardiac cath. Good thing he did. He ended up needing to bypass surgery. He said, if I would have put him on that stress test, he'd have went out then. So even though everything looks good, there's just something sometimes that leads them to think something's going on. So don't always think that everything's going to, show up wrong when something's going on. Trust your instinct. We talked about that. So our first one is troponin. So this is the one you hear most, right? So it's the normal protein specific to the cardiac myocytes. Detected in the circulation 3 to 4 hours after that MI starts. So, if they've been home for a couple hours, theirs may be high when they first get there. Just kind of depends. So the number we're giving you, we want it less than 45. Like I said, you may see it different. Anytime you look it up everywhere, you're going to find different ones. So just less than 45 is the normal one I've been using for the teaching part. So troponin is your first one. Myoglobin is your next one. This is a protein that binds oxygen and iron. Now, it's non-specific for MI because it can be seen 30 minutes after any muscle injury occurs. So if somebody falls, their myoglobin may be elevated, but if troponin never changes, then it's probably not heart, So that's why you can't use one just by themselves. So this is a normal 0 to 85. I don't even think they call them AMI profiles anymore. I think they just, do they, Mary? I don't think they do.
I don't know.
We used to call them AMI profile, and you knew when you looked at it, it was all for MI, So now I think they just draw it in. Okay, the other one is creatine kinase. They labeled as CK-MB. With this, the MB is specific to the myocardial cells. You do not need to know these numbers, 38 to 174 in men, 96 to 140 in women. But just know it's part of that graph, which I have on the PowerPoint for you guys. that shows what will increase and how long it stays elevated. So your troponin, your myoglobin, and your CK&B is your main markers that is looked at for an MI. Now there's others. We'll talk about those in a second here. Your CBC, it'll be elevated, right? Infection going on, excitement there. ABGs, maybe their breathing's off with their MI. EKG is going to show, are they Brady? Are they tachy? What's going on? Are they going into VFib? Echo again, and nuclear scans is going to show what's going on with that heart. Okay, collateral circulation. Have you guys heard of this? Coronary arteries are gradually narrow, and small branches may enlarge, and new ones form to get more blood to the myocardium. So this increases with age. So a lot of times this prevents an older person from having a heart attack. So, it's weird how it does it. So if you look that up, it's kind of interesting, but it does help. It does help with ones that's had heart attacks, help them from having it, even though they have all the precursors for it. This is your size of your heart attack. Now we talked, how I told you when we went over the 12 lead, next couple slides it's going to get into a little bit better. The one you're going to see the most is your LAD, right? Your left anterior descending. LAD is 75%. So if you see where that's at, what is this called right here? What do you hear people say they had when they had a heart attack? They had it where? Widowmaker. So you'll hear them say widowmaker. So that's their LAD artery. So that's the biggest one you're going to see have problems with. The right coronary artery, it makes up about 30%. That goes to the right atrium, the heart ventricles, and cells in the right atrial wall. And then circumflex is your other percentage that delivers blood to the muscles of the heart. So those are your main ones. So LAD is your main one. Consider the widowmaker due to the whole front wall of the heart can be blocked. Okay. So the next one kind of shows it a little bit more, and it shows on the 12 lead where that part of that heart was. It the inferior part? Is it the anterior? So remember how I said here's AVF, here's lead 3, V3, V2. You guys don't have to really get down to know all these different leads. That is not something you're going to diagnose, right? I mean, if you go on, like Mary's going to be a nurse practitioner, and you're going to have more, you're going to learn more about all this. Just know the different things like inferior MIs. They usually won't give morphine because it will drop their blood pressure too quick. So it just depends on the area involved to how it's going to be treated a lot of times. And again, they're not going to know that without doing the cardiac cath, all this kind of stuff. Okay. Lateral STEMI is a standalone indication for emergent reperfusion. Posterior MI indicates a larger territory of myocardia. The anterior is the left anterior descending artery supplying that blood supply to it. So that's where you're probably going to see the most is in there. Size of MI, this is just determined by the extent of the blood supply. Do they have any collateral circulation? And what is the oxygen demands on that myocardium? Your book also talks about the zones of tissue damage. Again, there's your left anterior descending artery. The ST segment is acute injury, T wave inversion, and a pathological Q wave. So the area of dead cells are known as zone of infarction. So we want to get prompt treatment to help preserve those tissues that we can before they get so necrotic they cannot be helped. Okay, so this is what I told you we get into, STEMI versus non-STEMI. So I know in our clinical on cardiac step down. We've had a lot of non-STEMIs, right? So STEMI is sudden, complete, 100% blockage. So that coronary artery, nothing is getting through. And you will see it on their EKG see how elevated. There's your normal ST segment. See how high that is. Okay. A non-STEMI is severely narrowed, not completely black, but there's some problems going on there. They're going to have to treat that also. I think, Bella, if I read your paper right, your patient that had the cabbage was a non-STEMI?
Yes, he was.
Okay, that's what I thought. So, so you see it, they still may need the surgery for a non-STEMI. STEMI, of course, is worse because they're completely black, and he had a 3 bypass, so maybe the others was complete. One of them might have been, who knows? So that's our difference, STEMI and non-STEMI. So just know your differences on that. And non-STEMI is about 70% of cases that they've studied on those. Clinical symptoms, okay, like we've seen on some of the ACLS videos, grabbing the arm, the chest pain, difficulty breathing, nauseous, vomiting, sweating. What is symptoms for women? What symptoms?
Isn't it GI or epigastric?
GI, epigastric, what else?
Nothing.
True, yeah.
Jaw pain.
Yes. Jaw pain, could just be back pain. I remember years ago on my cardiac clinical rotation, the one lady that had to come in for a cardiac cath and stuff, hers was just jaw pain. She had no other pain. They're getting better, like I said, about making sure they listen to women when they say the problems they're having, not just dismissing it as menopause or anything like that, that yes, you could be having a heart attack. So that's good they're doing that. Let's see, what else did they say about that one? This is actually my cousin's husband. He had 25 stents put in, 2 blockages they couldn't fix. He had a double bypass. So he let me use his. He sent me the picture and said I could use it to show you. I mean, he's doing good. It's amazing. I just couldn't believe it when he sent me this. But so you will see a lot of people will have a lot of stents. A lot of you have got to see cardiac cath. You've seen the radial approach, right? So that's good. Radial versus femoral. You can watch some of those for your extra credit. Always think of extra credit, and that will help you studying for tests, right? So think of it not just as extra credit as helping you do some test reviews. So MI, other diseases can make the prognosis and the risk worse. Diabetes, how many that's at heart attacks was they diabetic? Maybe their sugar was not under control, or maybe it was, and that just contributed to it. Thyroid disease, so excessive thyroid hormone stimulates that cardiac system, which can increase the heart rate, stroke volume, and cardiac output. Okay, so here's our medication. So analgesics. What do you think we're going to give them to help when they're having pain? We actually talked about this in lab that day.
Aspirin.
For pain, what did you? Morphine. So morphine's our analgesic. Because, pain increases that heart rate and that blood pressure. So we want to do something to decrease that cardiac workload. Remember Walter in our lab, he was having the chest pain. He went into all the different rhythms. So we tried to give him morphine. The fibrolytic, these are drugs that break down that fibrin in the blood clots, trying to restore that blood flow. Antidysrhythmics, of course, if it's a Brady, we're going to give them the atropine. If it's SVT, we're giving adenosine. Beta blockers again. So that helps decrease the dysrhythmias, the heart rate. ACE inhibitors, anticoagulants. Mona. Does anybody know who Mona is? You need to get to know Mona. Anybody want to
Yeah.
guess?
Morphine, oxygen, nitro, and aspirin.
Yes. So morphine, oxygen, nitrates, and aspirin. So get to know Mona. We'll talk about her more in just a few minutes here. Fibrolytic therapy, they don't use this quite as much. I think the ACLS videos will go over that a little bit. There will be questions on this on your written ACLS test. Now, next Thursday for your practice, all you need is your cards. You won't be doing your written test, so all you need is your cards because that's all we're doing is the code practice. So usually they try to get this in within 6 hours of the MI. So again, that's what they talked about in the ACLS videos. We don't want, if they're on an MI, we don't want to take them to Shelby because they can't do a cardiac cath at Shelby. They can't get this going, so they want to take them to hospital wherever they're at, that they can start the fibrolytic to break up that, get that blood flow going. Of course, if they've had bleeding disorder, stroke, uncontrolled hypertension, pregnancy, or recent trauma, they are not a candidate for this. And again, here are some more treatments. We're going to get into this more next week with the surgery. So it's going to these procedures are going to restore the blood flow and the oxygen. The VAD, he showed you his. We'll talk about that a little bit more next week. And cardiac rehab, they always want him to try to do this. It helps him with exercise, risk factor modification, education, counseling, stuff like that. Surgically, the cabbage, these are all things we're going to go over next week with the cardiac surgeries, the cabbage, the balloon and the stents, intra-aortic balloon pump, intra-aortic balloon pump. Mary, and who else got to see this with you, Mary?
I brought someone over, but I don't remember who.
So tell us what they did. Do you remember?
So that goes in and they're hooked up to a machine. Basically that pump is the blood flow within the heart, and then they can adjust how much it's actually assisting the heart. It basically gives the heart a rest.
There you go. And a lot of times, like my brother-in-law, when they found out he was blocked, they had him on one of these until they took him to get his cabbage done. So you'll see this, of course, in the units. They have to be in the unit to be on this. So, and we'll go over that again more next week. Patient with possible MI, of course, they're complaining of pressing or severe chest pain. They think they're having a heart attack, or they're waiting to see a doctor, especially you'll get men come in, because their wives made them usually. They thought it was just GERD or thought it was something like that, and here they're actually having a heart attack. So they've been waiting to see a doctor because they thought it was just, the GERD, and it was actually heart. So when they go to ER, these things are going to be done simultaneously. So I'm not going to ask you, okay, what's the first thing you do is they can get the ER, so one person may be hooking them up to monitor. Another one's got their oxygen on. They're giving them aspirin if they haven't taken it at home. They're pulling their labs, doing their ABGs, getting their EKG, so they're, like we talked about with the code situation, one person's doing the compressions while another one's pushing the med, right? So there's not your algorithms show you an order, but it's not like you have to worry that way because you're going to be doing, if somebody's with you, more than one at a time. The rest of this here. So ID, of course, put 1 or 2 in. That's a nursing judgment. That's not, you don't have to worry about having that order to get that. We don't use Demerol anymore anyway. You're going to use your morphine. So there's your Mona, right? Your morphine, your oxygen, your nitrates right there. And then we already talked about the aspirin. If they haven't took it at home, most people don't even wear nose. If they start having chest pain, they'll take an aspirin. So heparin again, we may give them that. Does not dissolve the clots, but we're trying to help with those. And we got to watch them for hemorrhage with the heparin. So make sure you know Mona. Again, we're going to treat any arrhythmias, right? Amiodarone, atropine, epi, may get a pacemaker, defib. We're going to be ready. If they're having MI, they may go into code. And we're going to send them to the cath lab. We want to know exactly what's going on, where it's happening. When they get up to the CCU, we want to make sure their oxygen, again, you know, their ABCs. Basic cares, try to decrease their anxiety. There's in their family, you know, they're scared, a lot going on. Decrease that cardiac output. Want to prevent any further clots going on. Treat that blood pressure and nutrition and diet, of course. That'll be ongoing teaching there. Again, complications, treatment of all is mostly those dysrhythmias. Treat when what they're causing that decreased output. Why, you know, which one is. Treat any CHF, any acute pulmonary edema, cardiogenic shock, you know. So we're watching for all this, and that's why usually they're going to be in the unit, because a lot can go on with that heart attack. Now, when they go home, cardiac rehab, we talked about nitroglycerin. They may be on aspirin, Coumadin, weight reduction, beta blockers, anti-anxiety meds, right? There's amiodarone, antihypertensive, antidepressants. A lot of, especially the older males, they'll be depressed about going through this. Elimination, sex education, right? You want them to not do this with somebody new in a new place. You know, they're gonna, you know, it's not good for them to try something different at this time. Alcohol, implanted defibrillators, right? Even let the family know about CPR in case they get through this again. Nursing diagnosis, ineffective tissue perfusion related to decreased cardiac output, activity intolerance, and acute pain, right? So these are all the things you're going to see them have. Ineffective tissue perfusion. So we want our nursing interventions. You want to manage that prescribed therapeutic regimen. So here again, your nitro, your oxygen, make sure they're doing their meds, they're resting, they're exercising, and stopping that smoking, right? That's a big thing there. Oh, okay, so the MI is done. Do you want a break before we start our last one in the